everyone. Welcome to your safety and infection control lecture. I know it's probably not your favorite topic, but it is worth your time. For both my RNs and PNs, 6 to 12% of your NCLEX is going to come from this category. So, what does it cover? Well, of course, your isolation precautions, right? Also, your restraints, safety devices, handling all of that hazardous material, responding to emergencies, safe at home, accidents, injuries, errors, all of that jazz. So let's just dive right in and try to keep this short. Isolation precautions is going to be the number one thing I want you to focus on. So, we'll kind of start from the top with what we consider your standard precautions. Okay. This is what we do for every single client, no matter what, even if they don't have something infectious. Hand hygiene, hand hygiene, hand hygiene. You know you have to do this before you go into the room, after you leave the room, no matter what. You also want to put on that PPE if you expect to be exposed to bodily fluids. So, even if they're not infectious, if you're helping with a chest tube insertion, for example, there is a reasonable expectation that something's going to come splashing out of that client. So, go ahead and put a gown on, disinfect equipment, and follow those safe injection practices. So that means one needle, one syringe, one time. We're not reusing any of that stuff. That's disgusting. Okay. Now, what if your client has something that could be transmitted or passed along from them to you? You got to protect yourself. So we've got three different types of precautions. Well, really four. Okay. So we'll start off with contact precautions. This is where we have that really for, because we've got contact and contact enteric, where we step it up a notch. We use contact precautions anytime direct contact with your client could cause transmission of this infectious agent. So think, if I've got something nasty and you come and touch me, and that could spread the infectious agent, that's when you're going to use contact precautions. So this is like things that grow on skin, MRSA, VRE, goop in the eyes, conjunctivirus, diphtheria. All right. RSV is contact precautions. That's one that gets confused very frequently. HSV, right? All those skin things. I've got it on my skin. You touch me and you've got it. That's something we need to prevent contact of. So, what are we going to wear? Well, we're going to try to put up a barrier to prevent contact. We need to do hand hygiene always and forever. And then we need a gown and gloves. All right. We're going to prevent contact. We're also going to use dedicated equipment. I'm not going to like put my stethoscope on somebody with MRSA, hop on over to the next room and put it on somebody else. That's going to spread the MRSA. And then I'm going to try to put them in a private room. If I don't have a private room, I'll cohort with the same infection. I can put clients with MRSA together because they all already have MRSA. Okay. Now, if my client has C. diff, norovirus, or rotavirus, I need to do something called contact enteric precautions, which is I'm wearing the same things, gown and gloves, but for hand hygiene, I need to actually wash my hands with soap and water. Hand sanitizer, not gonna cut it. It's not gonna kill those spores. So I could still transmit that disease if all I'm doing is hand sanitizer. Got to actually wash hands with soap and water. So that's why we have that extra little contact enteric. Okay, I've got a quick little memory trick for you because I know this is so much to remember. Here's a list of the most common diseases that utilize contact precautions. You can remember screws or superbugs, MRSA, VRE, conjunctivitis, RSV, that enteric, C. diff, norovirus, rotavirus, are wound infections, because remember, it's those things on the skin, and lastly, skin infection. So, contact precautions, remember screws. Next, we go up to droplet precautions. And these are going to be for diseases that are spread, no surprise, through respiratory droplets. Okay, so this isn't something that I'm going to spread to you by touching. It's something I'm going to spread to you if I cough or sneeze and a droplet comes out and then gets directly into your mucous membranes. Ugh, gross just thinking about it. All right. It's not a droplet that's going to live in the air for a prolonged period of time. It's something that has to make its way right on into your system in order to be spread. So think if I have the flu, I sneeze on you, it gets into your mucous membranes, ick, then you're gonna get the flu, right? These are typically your respiratory infections. The flu, pertussis, mumps, rhino, adeno, all those yucky viral infections, right? You cough, you sneeze on somebody, and they're gonna get it. So, how do we protect ourselves from those? We cover up our own mucous membranes. We put a mask on, right? If our mucous membranes are covered up, then we're not going to get those droplets. Then we're not going to get sick. Additionally, of course, try to get these guys in a private room if possible. You can also cohort with those same infections. Two people with the flu, they can go in the same room together because they've already got the flu. So, the memory trick to kind of remember all those most common infections that use droplet precautions is Spider Man. We've got scarlet fever and strep, P for paravirus, pneumonia pertussis, I for influenza, D for diphtheria, E for epiglottitis, R for rubella and rhino, M for mumps and meningitis, only the bacterial, and AN, that's for adenovirus. I always just think it's the respiratory viral infections when you get those gross flu, adeno, that's when you want to use droplet precautions. And last but not least, we have airborne precautions. These are utilized when an infection is transmitted by particles that are transmitted through the air. So I cough, I sneeze, I send out a particle, and it actually does remain infectious in the air. So it's not like the flu where I have to cough or sneeze it right onto you to make you sick. It's like TB, where I cough or sneeze, it goes out into the air and it actually stays there and can remain in the air and infectious for at least 10 minutes or so. Okay. So this is the scariest. This is the most serious. This is where we really have to take our precautions to a whole new level. So, of course, we got to do our hand hygiene. We also now have to wear a respirator. So, this is a N95 fit tested mask, a mask that's actually filtering out particles. Before, with our droplet precautions, our mask was just like a barrier, right? It was just like stopping my sneeze from going straight through. But this mask is filtering out small particles, filtering out that TB, filtering out measles, filtering out chickenpox, those teeny tiny little infectious particles that are living in the air. I'm also going to put this client in a private room with negative pressure that is filtering that air, and that door has to be closed. Okay. Gown and gloves if there's the potential for contact with bodily fluids. Why do I not always need gown and gloves? Well, contact with this client, touching them, that's not how I am coming in contact with infectious particles. If I just say, hold this client's hand, provide some therapeutic touch, that's not what is going to infect me with tuberculosis. It's breathing in the infectious particles. So, wearing the respirator, the N95, that's what's protecting me. I only need the gown and gloves if I suspect, hey, I might come in contact with these bodily fluids. My memory trick for those most common infections I need to implement airborne precautions for: 3 RVs. I've got my tuberculosis, rubiola, that's your measles. V is for varicella, your chickenpox, or VZV, your disseminated. And then S for SARS and smallpox. Now let's go over the correct order to don or put on your PPE. And that would be from the ground up. So gown, mask, goggles, gloves. If you do kind of, jazz hands above your head. Bottom up, gown, mask, goggles, gloves. If I'm being honest with you, as long as you get all of this equipment on appropriately, that's the most important part. What you really need to be careful about in the real world is making sure that you take it all off in the correct order, because this is when it is contaminated. And if you don't take it off correctly, you can contaminate yourself and actually get sick with whatever you were just exposed to in the room. So, taking off our PPE, this is called doffing. And we doff in alphabetical order. So, first we take off our gloves, then our goggles, gown, and mask. And we take our gloves off first because this is the dirtiest item. And you want to make sure you're grasping the outside of the glove with the opposite gloved hand, removing it kind of in a ball, balling it up like in the other glove so that you're not ever touching the outside of that gross contaminated glove. And then throwing that right in the trash and doing some hand hygiene. Okay. Then those goggles come off. And a really important part is you're kind of leaning forward so that anything dirty is falling forward, right? You're not like leaning back and letting all that gross stuff come over you. Same concept with the gown. As you take it off, kind of lean forward, gross stuff comes forward away from you. Okay. Hand hygiene, hand hygiene, hand hygiene. So, tricks to remember: we don from the ground up, jazz hands, and we doff in alphabetical order. Okay, let's look at an NCLEX question. You're working in an ICU. You've got a 62-year-old male. He was prescribed vancomycin and developed persistent watery diarrhea. So, which precaution do you take? Sanitize your hands before entering the room. Place them in a negative pressure room. Wear an N95 and a face shield, or use single equipment and leave it inside the room. All right. Single answer, simple, classic question. What do we think? We've got to use a little critical thinking here because they didn't tell us what type of infection this client had. Pause your video if you need some more time. What do you think? Right. If you said D, you had your critical thinking hat on. Absolutely. You should be using single equipment and using it, leaving it inside the room because I am worried about C. diff. They were on a broad spectrum antibiotic and then they developed watery persistent diarrhea. This all rings alarm bells, red flags for potential C. diff. So I'm thinking I need to put them on contact enteric. And that is why A is incorrect. I shouldn't sanitize my hands. I should wash with soap and water. B and C are both appropriate for airborne. And I don't need airborne. I need contact enteric, which is appropriate for D, single use equipment, and leave it inside the room. All right, next key topic is restraints. Let's go. The first question we have to answer is when it is appropriate to use a restraint. And on the NCLEX, the answer is not very often. Restraints are a last resort, and I want you to be very hesitant to choose that answer on the NCLEX. Basically, if they are a danger to themselves or somebody else, you can use a restraint. If not, don't pick it. All right. So if they're trying to harm themselves, if they're trying to harm you, they're pulling out their lines, tubes, or drains, then it is appropriate to use a restraint. For any other reason, I want you to choose a less invasive option. If the family requests it, somebody else requests it, you want to, somebody else just thinks it'll be easier, it is not appropriate to use a restraint. And we always want to remove that restraint just as soon as we possibly can. There are four main types of restraints that you'll see: physical, like actually holding down the client; environmental, like a seclusion room or unit in a psychiatric facility; pharmacologic, like medications we might administer; or our mechanical restraints. And this is probably what you're most familiar with. We've got a few of these that you may have seen. Soft wrist restraints are probably the most common. These are soft around the wrist and then have a clip where the client is not able to get out. We also have mitts. These are like little soft boxing gloves, and these are great for our clients who might be delirious trying to remove lines, tubes, or drains, but they're not actually trying to harm anyone. So they're a danger to themselves because they need that IV, and this mitt will remove their dexterity and ability to do so, but it's not going to remove their ability to harm someone. So this is not for your client who's violent because they can still punch you through that mitt, but they're not going to be able to remove their IV. Next, we have a vest, which is not commonly used anymore. It used to be common for a client who was delirious and trying to get up out of bed, but they were a fall risk and it would keep them in bed or in the chair. But we found that when they scooched down in bed, it was actually a choking hazard because that vest could kind of go up around their neck. So the vest is not common anymore. What is common, especially in the world of pediatrics, is a posy bed or a posy crib, which is a bed or a crib with this mesh surround that keeps the client or the pediatric client in their crib or in their bed so that they can't actually get up and get out. So, again, if they're violent, probably not the best option. But if they're delirious, trying to get up, trying to escape, it will keep them contained. Now, how do we apply a restraint? Make sure you can fit two fingers under that restraint. We never want to cut off circulation. So always check that distal to that restraint, we have a pulse, we have circulation, we have good capillary refill, we still have nice, warm, intact skin. We never ever attach that restraint to something that can move, all right? Think bed rail. This is a key NCLEX question, all right? That restraint does not get attached to a bed rail. That bed rail goes up and down. It doesn't get attached to a chair. It can get attached to the bed frame. That frame of the bed, most hospital beds have an actual little place for restraints that is not going to move. That's where we put them, okay? And we always use a quick release knot. Because what if there's a fire? What if there's an emergency and we got to get that client out of restraints ASAP, okay? We don't want to be fooling around with knots and then they get stuck and then we have some sort of catastrophe. So quick release knot. Velcro and buckles are more common nowadays because we can just boop, get them out of there really, really fast. Now, you might get some questions about what sort of things are actually not considered restraints. This can get a little confusing. Let's say you have a pediatric client that keeps bending their arm and occluding their IV that's in that AC, in that elbow. So you pop a little arm board on there, put some Curlex on, you immobilized their arm. Is that considered a restraint? Nope. Arm boards for IV stabilization, that's part of their medical care. Same thing if you immobilize them for a procedure like an MRI, a surgery, or you're immobilizing a joint in a splint or a cast. What if you put all of their bed rails up to protect them during a seizure or transport them? None of those things are considered a restraint. It's part of their medical care. Same thing about putting the bed rails up in a crib if it's a baby. If it's a helmet, orthopedic device, part of medical care. And lastly, if law enforcement is using handcuffs, that's law enforcement. That's not you. That's not a restraint. Now, we talked about those different physical types of restraints. When your provider orders the restraint, the order will come in one of two ways, as a nonviolent or a violent restraint. So it's not actually going to physically look different. This is just how the provider orders it. And it's based on the reason for the client needing the restraint, right? Does my client need that restraint because it's Grandma Jane? She's delirious trying to pull out her IV. She's nonviolent. Or is this Grandma Jane who's sundowning and trying to give me a black eye? She's violent, right? So the restraints look exactly the same. They're the soft wrist restraint, they're the same physical device. This is just the reason that we're ordering it. And it's important that you know this because it changes your documentation and assessment requirements, okay? If it's a nonviolent restraint, that healthcare provider needs to see the client within 24 hours. You need to assess the client every 1 to 2 hours per that unit policy, and your order is good for 24 hours, okay? A little bit of a lighter requirement. If that client is violent, they're at risk of harming themselves or others, that provider needs to be at the bedside within an hour. And you are assessing that client every 15 minutes, all right? Checking that you can put a finger under the restraint, looking at circulation. And that restraint order is only going to be good for a little while. It actually depends on the age of the client. For an adult, 4 hours. For a child, 9 to 17, 2 hours. And for a young child, less than 9, only an hour. That means if you have a pediatric client less than 9 years old, healthcare provider to the bedside within an hour, and that order is only good for an hour. Every hour, new order, provider to the bedside within the hour. And you're assessing every 15 minutes. So you really want to de-escalate this client and get them out of violent restraints. We don't have time for this, right? We want to do everything we possibly can to de-escalate this situation so that we don't need the violent restraints. This is our last resort. And I know that you guys know this, but it would be a horrible thing for me to not say it. Document, document, document. If you do have to put your client in restraints, you need to document the reason, when you started, when you stopped, and the plan of care, especially what you're doing to de-escalate and get them out of those restraints. Document that you checked their skin, because if they end up with skin breakdown, that's considered our fault. We put them in those restraints. If the restraints break their skin, that is on us. You also need to document that you're providing them with their basic human rights, that you are allowing them to get up and toilet. That might be that we're providing them with a bedpan. Maybe they have a Foley catheter in place. But in some way, shape, or form, you're documenting their toileting, their elimination requirements. Same thing with nutrition, that you're offering them food, you're offering them hydration, that you're offering them range of motion. You have to document those basic human needs. You have to document those assessments. Okay, so important. Let's do a practice question on it. Which of the following situations represents an appropriate time to place your client restraints? Select all that apply. All right. Pulling at their lines, tubes, and drains. Family member asks you. You feel it's necessary, or if they're a danger to themselves. All right. You guys know it. Pause if you need more time. But you know it's A and D. Danger to themselves. They're pulling at their lines, tubes, and drains. All right. So lines, tubes, and drains, that would probably be our nonviolent danger to themselves. That's an example of our violent restraints. But if a family member asks us or we feel it's necessary, that's not going to be an appropriate time to place our client in restraints. Next up, how do we handle hazardous material? So we can classify material in a few different ways. First, we'll talk just about medical waste. This is any trash that's non-hazardous. So your paper, your leftover food or utensils, tissues, you're just going to put all this junk in a regular trash can. Now, if the trash has any chance of being infectious, like a used sharp, bodily fluids, a wound swab. Then we're going to dispose of it per facility protocol in the sharps container. And this is what is considered infectious waste because it could be infectious. All right, now a step up from that, we have our hazardous waste. This is hazardous. It could be a danger to the staff, but it's not necessarily due to infectious risk. So maybe it's a clean sharp or a med that's hazardous, like a blue bin drug or a chemo drug. So these are going to go into a blue bin, disposed per the facility protocol. Lastly, we have radioactive waste. So, of course, anything involved with radiation could be a med, an implant, tubing, PPE that was used while you cared for a client who was receiving radiation. And you yourself, as a brand new nurse with 2 weeks of general nursing knowledge, are not going to be disposing of radioactive waste. We have specialized team members with specialized training who are going to dispose of radioactive waste. But you might care for a client who's receiving radiation. So, how do we do this? The first principle you need to be aware of, reducing exposure. So, keep your distance. When possible, you never, ever, ever touch an implanted radiation device. You minimize the time you spend in the room, so cluster your cares. If you're going to go in to help them to the bathroom, go ahead and bring in their meds, check their blood glucose, do all the things together, and minimize the number of staff members that are going to go in there. You're also going to wear PPE while you're in the room: double gloves, goggles, shoe covers, N95 level respirator or higher, and something special called a dosimeter. We've got one of those down in the picture there. It is a device worn by staff to measure your exposure to radiation. So it tracks, it like picks up on how much radiation you're exposed to and keeps track of those cumulative levels. So you wear it every time you go into the room and it tracks that cumulative dose of radiation. And when it gets up to a limit or a high enough level, you should be assigned to a new client so that you're not going in over and over and over and getting too much radiation. Now, caring for clients with these radiation devices. Immediately discard any bodily fluids in that hazardous waste. All right. So, that waste, it's a potential danger to staff. So, the urinal, waste from a blood draw, if you use a towel to clean up a bodily fluid spill, that waste could be radioactive. We're going to put it hazardous waste. We talked about clustering the cares so you're not in the room all day. And the linens, the trash, we're going to leave it in the room for proper disposal. Next up, let's jump into emergency responses. First, how do we do CPR? Hopefully, we never have to do it, but you just might. So, if you come across an unconscious client, your first step is to try and wake them up. Yell and shake them. Do a sternal rub. Hey, hey, are you okay? Step 2, check their pulse. On an adult, this is the carotid. On an infant, this is the brachial. Key NCLEX point: never check the pulse for greater than 10 seconds. If at 10 seconds you have no pulse, shout for help, pull that code bell. If there's no pulse, after 10 seconds of checking, you start chest compressions. Here are the 3 things you need to know about chest compressions. The rate is 100 to 120 beats per minute. You want to compress on an adult to a depth of 2 inches, and you have to allow their chest to fully recoil. That means when you press down, you let it come all the way back up. This is so their heart can refill with blood. Otherwise, if you're pressing down and down and down too fast and not letting it come back up, the heart's not filling back up with blood and you're not actually circulating good blood back out to the body. So your CPR is not even effective. Now, while you're doing chest compressions, have somebody go get that crash cart. After 30 of these high quality compressions, you'll give 2 rescue breaths. And you'll continue this cycle of 30 compressions and 2 breaths for a total of 2 minutes. You're going to be pretty tired at this point, all right? This is no joke. At the 2 minute mark, that's when you stop to check the rhythm and the pulse. If you don't have a pulse at this point, go ahead and switch compressors. Hopefully, you've got someone to help you at this point and resume those compressions. Here is a key takeaway: never stop those compressions for more than 10 seconds. Remember, we never checked their pulse for longer than 10 seconds either. This is because breaks in compressions for longer than 10 seconds significantly decrease our client's chance of survival. So don't check that pulse for longer than 10 seconds. Don't stop those compressions for longer than 10 seconds. The longer you're on that chest, the more high quality compressions you're doing, the better chance your client will survive. Now, during that break in compressions, we were checking the pulse and we were checking the rhythm. We're analyzing that rhythm to see if we can shock it. And we use an AED. This is when we put the pads on that client's chest and we see if their rhythm can be shocked. So slap those pads on there. It's going to analyze. And if it says shock advised, we're going to resume compressions while the device charges. As soon as the AED is ready to give that shock, we're going to yell clear, make sure everybody backs up, isn't touching that client, and deliver that shock. Now, key takeaway: as soon as the shock is delivered, immediately resume compressions. There are some key differences for infants. If you have two rescuers, instead of doing 30 compressions and then 2 breaths, the ratio changes. Now we will do 15 to 2. Instead of using your palms, we'll use 2 fingers like you see below in this photo. And instead of compressing to a depth of 2 inches, we're going to use a depth of about 1/3 their anterior posterior diameter. That's their chest wall from front to back. Quick knowledge check: you're at the bedside of a 51-year-old client who was found unconscious. CPR is in progress. Which of the following actions would require you to intervene? All right, pause your video here. Click play when you're ready for the answer. Did you say A? You are correct. For a 51-year-old, that's an adult client. Our correct ratio is 30 to 2. 30 compressions, 2 breaths. 15 to 2, that is the compression to breath ratio for 2 rescuer infant CPR. All right, now we're going to get into some accident, injury, error prevention. First, we'll look at clients who are cognitively impaired. And a big thing on the NCLEX is keeping them safe with how we assign them to rooms. So you'll often see we want to put these clients closest to the nurse's station. Advocate for families and close friends to visit. This can be really helpful for orienting them and keeping them as safe as possible. We also want to decrease their stimuli, limit noise, don't have the TV and radio on in the background all day long. Routine is key. Brush their teeth in the morning, have a group outing, go to bed at the same time. This is going to prevent delirium. And we really want to frequently reorient that client. It's helpful to have a calendar with the date and the nurse's name. Sometimes we use like a little whiteboard in the room to do this and put the plan for the day. This will help keep the client aware of what is going on. Now, outside of the hospital or facility environment, let's talk about what we can do at home to keep this client safe after they've been discharged. Of course, we want to start with assessing. All right, what's the lighting situation? Do they have to go upstairs to get to their room? Are they walking over throw rugs and cords, fire hazards? Can they even get out of their home if there's an emergency? Keep an eye on what the situation is so that you'll know what you need to maybe modify to do to make it safe. So, if they are at risk for falls, first of all, I know you guys know this, but get rid of those dang throw rugs. They're going to trip over that. Make sure there's no cords or wires. Again, they're going to trip over that. We also want night lights. Assistive hardware can be very helpful, okay? Grab bars, raised toilet seats, handrails. This is going to help prevent a fall. We might even want to talk to them about a fall alert system so that if they do fall, they can get help more quickly. Now let's talk about preventing these errors, injuries, and accidents. Long list of ways that we can go about doing this. First and foremost, identifying our clients. All right. You have to identify your client, and you should be doing it with two client identifiers. Here's a list of appropriate ways to identify your client: their name, their date of birth, their medical record. You should not be using their room number. Clients can change rooms, okay? They might move from room 7B to room 11. And if you use that, then you could be misidentifying your client, okay? So that's a big no no. And I've seen that come up on the NCLEX a lot. Nowadays, we often use our EMR with barcode scanning to scan that bag and then have that client verify for us, hey, what's your name and what's your birthday? Okay. Now, we also want to assess allergies. At first contact, we note it in the medical record and we place one of these nice bands on the client. They're usually red, like you see down there. As soon as they're admitted at that first contact, we're gonna go ahead, ask them about this, and put one of those bands on them if they've got those allergies. Another point to make is that some clients with allergies can have cross sensitivities. So let's say I have a latex allergy. I am more likely to also have reactions to strawberries, bananas, and kiwi. I know that sounds bizarre, seems totally random, but there are components of those that I'm just more likely to react to because of my latex allergy. So keep those in the back of your mind. They're known to come up. What if my client does start to have an allergy? Here's what you need to know about it: airway, airway, airway. Look for wheezing, tachycardia, and that cool, clammy skin. What do you need to do for them? Epinephrine. We're going to grab an EpiPen and firmly press it into their outer thigh. You should hear a click and hold it for 3 seconds. That will deliver the epinephrine and open up that airway. The next way we can prevent an injury is placing our children in car seats. We have to do so correctly. First of all, they go in a rear facing car seat until they are 2 years old. They can go forward facing at 2, and that car seat always goes in the back. Never, ever, ever does a car seat go in the front of the car. Children have to stay in the back till they're 13. All right. Once they're a teenager, they can come sit in the front with you. No puffy jackets on under a car seat. Here's why. Look at that bottom picture. If we've got a puffy jacket on under my car seat, when we're buckled in, we're not really cinched down tightly. There's so much space under that buckle that when a car stops suddenly, the child will not be secured properly. I also need to make sure that that chest clip is all the way up at the breastbone. If you look at that picture just under my video, you see that if that chest clip is lower, it's actually sitting just below the abdominal organs. And if a car stops suddenly, the chest clip will go right into all those organs and cause internal damage. But if the chest clip is all the way up at the breastbone, it will be secured over the rib cage and protect the internal organs. So keep it up high. Next, we have fire prevention. This is really important in a hospital because we have so much flammable equipment. So check that equipment at the beginning of the shift and always know where your emergency shutoff for oxygen is because we know oxygen is a gas. Which reminds me, you should never ever smoke around oxygen. I always think of the movies where there's the old guy dragging his oxygen tank smoking at a casino. It's just a setup for an explosion, okay? Don't be that person. Then you've got your obvious: don't lock a door and keep electrical equipment away from fire. If there is a fire, we've got two little things you need to remember. First, we race and then we pass. Race is the order of events that we will use if there is a fire. We first rescue anyone in immediate danger. Then we activate the alarm. C stands for contain. So let's say the fire happened in someone's room. We're going to close all of the doors so that we keep the fire in that one room. We contain it. And lastly, E, we extinguish the fire. We pull out that fire extinguisher and we try to put out the fire if it's safe. Pass is how we will try to extinguish that fire. It's how we use that fire extinguisher. P stands for pull out the pin. A, we aim at the base of the fire. And then S, we squeeze the handle and sweep from side to side. Let's look at an NCLEX question for a quick knowledge check here. You're working on a busy med-surg unit. A fire breaks out in a trash can in a client's room. What's your priority? Do you pull that fire alarm, remove the client from the room, contain the fire, or get that fire extinguisher? Now, really, all of these sound like actions that I probably should take at some point. So think back to your little memory trick. What order do you go in? It's B, right? Race. We rescue, activate, contain, and then extinguish. Now let's talk about some precautions, not your isolation precautions, but some other precautions you can take to keep your client safe. Starting off with seizure precautions. If you know your client is at risk for a seizure, the first thing I want you to do is check that oxygen and suction are available and working at the start of your shift. All right, I've been burned by this before. I walk in, I'm tired, it's night shift, I didn't sleep, and I quickly glance that like the oxygen and suction are there, but I don't check that they're working. Okay. If something goes wrong, that is on me that I can't quickly access my oxygen and suction. It's the number one thing you need to have ready to go at the bedside if your client seizes. So take the 2 seconds and actually check that it's functioning. Okay. You'd be surprised how many times it's like kinked off, not plugged in, doesn't have the right connection. Just fix it. Okay. Now, also pad the side rails. Okay. You don't want your client rolling onto this hard side rail, hitting their head, knocking themselves out. We also want loose, non restrictive clothing, remove any jewelry, anything that could injure them. Name of the game is keeping your client safe. So we just want to create an area where they're not going to get injured. During a seizure, we do not put anything in the client's mouth, okay? No tongue depressor, no bite block. Don't get your hand anywhere near the client's mouth, okay? They could bite your finger right off. All you're really going to do during a seizure is once again keep them safe. So remove anything around them that could cause them harm. After the seizure is over, you are going to turn them on their side in case they vomit so they don't aspirate. And of course, throughout the event, we want to be pulling that curtain and giving the client privacy. Now, speaking of aspiration, here are aspiration precautions. We want to identify anyone who's at risk for aspiration. First client that comes to my mind here is the client who's just had a stroke, anyone with dysphagia. So assess your client during meals, watch them swallow. Now, if your client's had a stroke, they're having trouble swallowing, don't rush them while they're eating. Let them take their time, small bites, alternate between solids and liquids so that that solid can have something to wash it down. We also want to sit upright, okay? If you're slouching down, you're more likely to choke on something. The diet we typically use if you're at risk for aspirating is thickened liquids, okay? When something is thicker, it's more likely to go down the right tube. Thin liquids, higher risk for aspiration. We also want to do oral care after meals. Any chunks left around, they can slip down the wrong way. We can aspirate. Stay upright after your meals too, so that you don't slouch down. Something goes down the wrong way, aspirates into the lungs. Next, we have neutropenic precautions. This is like reverse isolation, okay? This is when your client is at super high risk for infection. So we have to protect them from us. It's not that they have some sort of disease that we want to guard against. We actually have to guard them against getting any diseases from the outside world. So maybe they're going through chemotherapy. Maybe they had a transplant and they're on an immunosuppressant medication. For whatever reason, their immune system is not up to par. They have a low neutrophil count. Their immune system, it is not going to be able to fight off any infection. So I don't want to bring anything into the room that could cause an infection. That means nobody sick. Anyone who does come in the room, they best be washing their hands. Strict hand hygiene is numero uno. I also don't want to bring anything in that could carry germs like fresh fruit, fresh flowers, or vegetables. All right. I know in general those things sound really nice, but they can carry bugs with them. We want to limit the number of people coming in. No live vaccinations. We don't want water sitting out for more than 4 hours. We just want to take care that anything coming in is as clean as possible. Lastly, everyone's favorite fall precautions. We put everyone on fall precautions, right? This is your yellow bracelet. A lot of times we do a bundle and we give them everything yellow socks, door sign, anyone at risk gets their fall bundle. So, some of those people who might be at risk are older clients or cognitively impaired clients. Maybe they have a bunch of equipment cluttering the room, so we're at a tripping hazard. We want to do everything we can to prevent these clients from falling. So, first of all, let's make it less likely that they're going to have to get up in the first place. Call, don't fall. Put that call light right by them so that they'll call you instead of trying to get up by themselves. Get that unnecessary equipment out of the room. Turn the light on so that they can see where they're going. And put that fall bundle in place, okay? The door sign, the socks, the bracelets. That way, everyone will know they're at high risk. And we know some people are going to get up anyways, so turn their bed alarm on. This is a little nifty contraption that will siren or alarm when the client gets up so everyone in the hallway knows someone who's not supposed to be out of bed is up. They'll run to the room in case they're about to fall. Offer to get them up to the toilet frequently. That way they don't need to pee when you're not around and try to get up on their own. Now, I mentioned that bundle. We know yellow's the universal fall risk color. So you see someone decked out in yellow, you see this sign on their door, and you kind of know what's going on. You're supposed to update this routinely so you kind of know what risk factors they have and what other interventions you're supposed to be taking to limit their risk of falls. This will keep all of the team members on the same page and hopefully prevent your client from falling. And all of us should be using these basic little ergonomic principles when we're lifting and moving our clients, whether they've fallen or not. So it might seem silly, but protect your back now as a new graduate nurse. So bend with your knees and twist with your hips. While you're charting, sit upright. All right. I'm guilty as charged. I'm a total sloucher. Like, I think I look good. And then if someone shows me a video of myself, I'm all slouched over looking down. You should have to kind of sit up, hands straight, and feet on the floor. That's the right posture for charting. When you lift something heavy, keep the weight at the center of your body and lift with your legs, not your back. Don't forget to ask for help. Nursing is a team sport. And you did it. That's a wrap on safety and infection control. All these key topics making up 6 to 12% of your test plan. So don't forget if you need a little more TLC in this area, we've got your small groups, we've got private tutoring. You can scan this QR code and you can always shoot us an email right over there, NPlex Tutors at Archer Review. Always happy to chat with you answer your questions, and just let you know how we can help. We know that this is hard work, but nothing worth it was ever easy. You can do this, Archer Review. I'm Morgan, and I'll see you next time.